So let's go, Eric, to a second case, which really gets at the whole question of frontline therapy. So I'll describe the case for you, and then let our doctors and our audience know your thought process, how you integrate the conversation, and then how you make a decision. So we have a 61-year-old pharmacist who experiences a 4-month history of weight loss and fatigue. Imaging reveals lung, bone, and liver mets, as well as a 7-centimeter right renal mass with renal vein invasion. You see the patient in consultation, appears a bit frail, exam is unremarkable. He's mildly hypoalbuminemic, an albumin of 2.9, hemoglobin of 9.6, a calcium that's a little bit elevated at 10.6. A biopsy confirms of his lung, confirms a CD10 vimentin RCC positivity with some clear cell and sarcomatoid features. So he's in front of you, and you're talking to him about options for care. So let me kind of hear that discussion.
So this case, pretty complicated case. There's a lot of elements here. So we have an individual who's not been previously treated, but has poor performance status. And also, if you look at risk features, there are some good algorithms, the Memorial Sloan Kettering and also the international group algorithms, where we look at various features like anemia, performance status, calcium levels, LDH, leukocytosis, thrombocytosis, and we can actually, these are very powerful tools to get an idea of what the prognosis of the patient is. Right. And if the features that this patient has, we know that this patient's in that high risk or poor prognosis group. So that immediately, we know in 2015 that that's probably a far more powerful predictor of outcome than any therapy we can give to this person. So just to interrupt
for a second, Eric, I just want to make sure that our audience hears this. So when you see a patient in your clinic, you use an algorithm, whichever algorithm it is, and try and anticipate, based upon whether it's MSKCC or the international group, kind of what the natural history of that disease will be in that person?
Yes. Yeah, and I think that's really important, because the decisions you make then with regards to, do you perform a cytoreductive nephrectomy on this person or not? And also with regards to looking at the NCCN guidelines and also the level 1 evidence with regards to which agent to choose in the frontline setting, they're all important. So although it's not, this is somewhat subtle, I think, but in terms of should one perform a cytoreductive nephrectomy or not, this is the sort of individual, if you look at the SWOG data that were generated now close to 15 years ago, this is the sort of individual who has a relatively short survival, and the net absolute gain of survival from a cytoreductive nephrectomy is in the order of 1.5 to 2 months. So subjecting this individual to a fairly large surgery at this point in time probably wouldn't be wise, and I would not offer this person a cytoreductive nephrectomy.
And if this patient, just again for clarity for our physicians, if this patient was not hypoalbuminemic, if his hemoglobin was normal, if his performance status was 0 despite having widely metastatic disease in these multiple areas, those are the kinds of things where you would start to revisit whether or not to integrate nephrectomy into that patient population?
Absolutely. I mean, we do know, again, these are old data, these are pre-anti-angiogenic therapy data, but we know that an integration, as a number of us have talked about, the integration of surgery and systemic therapy is an important part of the practice of medicine. And so there you start thinking more about perhaps doing an upfront cytoreductive nephrectomy and then following up systemic therapy. This individual also, he has bone metastasis, liver metastasis, has some other features that worry us. So then the next question is what type of systemic therapy to use. And the major systemic therapies that we have that are currently FDA approved are high-dose IL-2, which this is not the sort of individual we'd be thinking about here, because they're not in good shape. We think about temsirolimus, where the randomized phase 3 data demonstrate that in poor-risk individuals, temsirolimus was superior to interferon. We don't have any mature data yet about temsirolimus versus an anti-angiogenic therapy, but temsirolimus would be a good option. Would it be wrong to use pazopanib or sunitinib? No, but we don't have level 1 evidence comparing to temsirolimus, but I think that would also be a reasonable thing. I think the key thing for this sort of person, what my effort would be to get him on a good systemic therapy to try to cool the disease down, to reduce the impact of the disease burden on the patient's overall performance.
And again, turning the tables a little bit, and if this person were had fewer poor risk factors and was more in the good and intermediate risk, and maybe this is the person you had taken to cytoreductive nephrectomy and recovered fairly, and was ready for systemic therapy, what would be the conversation? Would the conversation be a little bit different than in this patient, for example, where temsirolimus seems to be the treatment of choice?
Yeah, no, so let's take it to a slightly further extreme. Let's say this individual has good performance status, has relatively low volume lung metastases, but not something that would be reasonably resectable. The individual is in his early 60s. Then in 2015, you still have a conversation about what about high-dose IL-2 versus anti-angiogenic therapy. The one feature here, and again, these are retrospective data that you've generated, is sarcomatoid renal cell carcinoma probably would be a contraindication to using high-dose IL-2 because it just doesn't seem, based on these data, that sarcomatoid responds as well to high-dose IL-2. So probably in that situation, we'd come down to using an anti-angiogenic therapy.
So Tom, without putting you on the spot, but putting you on the spot.
Awesome.
You know, one of the things that oncologists have to navigate is we have two small molecule oral TKIs that are commercially available for kidney cancer. We have sunitinib, which has now been available since 2006. We have pazopanib, which is now available. We have the COMPARS trial, which tried to help us understand the difference with respect to efficacy as well as toxicity. We have a Pisces trial, which tries to help us navigate through patient preference, which is becoming an increasing part of how the FDA looks at drugs in terms of patient-reported outcomes. Help us understand how you work through that data when you decide sunitinib versus pazopanib in an appropriate patient that needs a TKI.
Wow. Okay, Bob, very interesting question. As you know, there's really probably not a right answer in choosing. So I think I always phrase things like if I was in the Nancy Grace court of law and a court of public opinion, and I'm taking out the evidence, it would suggest that either one of those agents are probably reasonable choices. You couldn't really fault a physician for choosing one drug or the other. With that said, certain factors will play into a choice of discussion, and they're going to be patient and physician and disease-related factors. So if we talk about patient-related factors, they're going to be just the comorbidities of the patient. If this patient was having LFT abnormalities or because of liver metastases or any evidence of that, that would maybe make me not want to use the pazopanib as first. There are going to be disease-related factors, how advanced the symptoms are in the patient, how quickly we needed to get tumor shrinkage. There's a belief by some that sunitinib may just have a little extra punch in its ability to produce a response rate, which may choose some people may choose sunitinib over that. And then there's going to be, probably other factors that play into that's the availability of the drugs. But I think in my practice, I've kind of used them interchangeably. I'm a big clinical trial center, as you know, so we end up, sunitinib is the comparator arm for the major phase 3 trials going on right now, so most of my patients are getting that by default. But I would have no problem, for instance, in giving patient pazopanib. So I think either one of those are going to be effective options for the patient.